So we're now into chapter 38 where we'll be talking about the thyroid, as well as some bone diseases that can occur due to different hormones. So the thyroid hormones are T3 and T4. They have long names. You can refer to them as T3 and T4. That's fine with me. That's probably what you'll most commonly see them referred to. They help regulate tissue growth and mitochondrial metabolism in virtually every cell, especially muscle and nerve cells. The secretion of T3 and T4 is again under the control of the hypothalamic anterior pituitary thyroid axis. So the hypothalamus secretes thyrotrophin releasing hormone, which travels in the portal vein down to the anterior pituitary, which releases thyroid stimulating hormone. That travels through the bloodstream to the thyroid and tells the thyroid to produce T3 and T4. So thyroid cells are the only cells that can absorb iodide and combine it with the amino acid tyrosine to make T3 and T4. And one of the ways that we get iodide in our diet is from table salt, not kosher salt, but the actual Morton's table salt. So T4 is converted to T3 in the body, just an FYI. So T3 is a little more potent because it acts quicker. It doesn't have to be converted. The difference between the two is just one single iodine molecule. So T4 has that extra iodine molecule, it's removed and becomes T3, which is actually the active hormone. So again, it's involved in metabolic processes, and it acts all over the body. So it generates heat, it can control heart rate, it can control strength of cardiac muscle contraction. It does a whole bunch of different things in the body. And as you're going to see when we talk about lack of thyroid hormone in children in a couple seconds, you're going to see that it's a pretty serious hormone, and without it, it has very serious consequences. We're going to talk about hypothyroidism, which is not enough T3, T4, and hyperthyroidism, which is too much T3 and T4. So hyposecretion of T3. It can be the result of a glandular destruction, whether it's exposure to X-ray or lack of iodine. It can be from pituitary dysfunction. There's a couple different things that can cause hyposecretion. In addition, hyposecretion in infants and children can cause cretinism, which is physical and mental retardation. And again, as I just mentioned, you can see how serious it is. Without this thyroid hormone, people suffer serious effects. So hyposecretion of T3 and T4 in adults results in non-toxic goiter. So there's a negative feedback loop here too. We've talked about this before. When TSH from the anterior pituitary is being sent to the thyroid to make more T3 and T4, if there's no T3 and T4 to answer the pituitary and the hypothalamus, the thyroid just keeps getting bombarded with more and more TSH. When little or no T3 and T4 circulate in the blood and the thyroid hormone is continued to be stimulated, it causes glandular enlargement. And you can see the picture on page 648, how big those glands can get. So that's lack of negative feedback. There's no T3, T4 to shut off the TSH stimulation. So how do we fix this hyposecretion? Almost always hormone replacement. There's really no other answer in this case. There are synthetic and natural T3, T4. Synthetic levothyroxine would be your most common choice, and desiccated thyroid from pigs would be your natural choice. The two do vary based on their onset of action and duration, as well as their potency. And generally, once somebody finds a medication that works for them and they have a dose that they've settled on, switching is not advised because it can cause the hormones to fluctuate a little too wildly. They're given in the smallest dose possible and raised incrementally, and generally this is a lifelong therapy for patients once they're on it. So generally, levothyroxine is somewhere between 100 and 200 micrograms per day. It's given before breakfast because absorption can be inhibited by food and other medications. They also have an IV formulation that's used in myxedema coma, and myxedema is a total absence of T3 and T4. And it's characterized by round puffy face, dry skin, hypotension, bradycardia, and intolerance to cold temperatures. And left untreated, it can develop into a coma, which is called myxedema coma, treated by that IV levothyroxine in higher doses than what you would see for just daily replacement therapy. So Levothyroxine is generally given the same time each day, again, to sort of maintain that constant balance of hormone and not throw the body off by being too high or too low. Indications, always used for, of course, hypothyroidism from any cause, as well as the treatment of thyroid nodules and thyroid cancer because it can suppress TSH. Adverse effects is essentially the opposite of hypothyroidism. It's hyperthyroidism, so usually due to overdose. And that is going to be the exact opposite of any of the symptoms of hypothyroidism. So increased blood pressure, heart rate, chest pain, jitteriness, etc., weight loss, menstrual irregularities, and heat intolerance. So they should be used in extreme caution, as you can see, with patients who have cardiovascular disease, hypertension, congestive heart failure, or chest pain, which is that word you see there, angina, or in renal disease. So the reason being because they increase sympathetic tone and can exacerbate those underlying diseases. They're also not to be used for weight loss, even though that can be a side effect. Usually in patients that have a normal thyroid function, if we give them levothyroxine, we aren't necessarily going to cause them to lose weight. We may do more harm than good. Long-term use of levothyroxine or thyroxine products has been associated with osteoporosis, so we keep an eye on bone density when we're giving these medications. Drug interactions. Again, we talked about taking this medication on an empty stomach by itself. It specifically says cholestyramine will bind to the thyroid hormones and prevent their absorption. Long-term therapy with lithium, chlorpromazine, or imipramine can produce hypothyroidism, so the dose of levothyroxine may need to be changed over time. Finally, thyroid hormone replacement can cause an increase in the required dose of insulin or oral hypoglycemic drugs in diabetic patients because these hormones, because T3 and T4 increase blood glucose levels. Moving on to hypersecretion and calcium homeostasis. Hypersecretion or hyperthyroidism can be caused by tumors or autoimmune disease called Graves' disease, where the body mistakenly attacks the thyroid gland, and that's what autoimmune means. So hyperthyroidism is associated with an increased secretion and circulation of T3 and T4, which results in added heat production, increased cell metabolism, tachycardia or fast heart rate, muscle weakness, anxiety, and weight loss. Hypersecretory conditions may be corrected with antithyroid drugs, irradiation of the thyroid, or surgical removal of the overactive tissue. Usually it's a combination of these methods. Sometimes we have to get these patients to a normal level before we can remove the tissue. So we might give them one medication and then move on to another therapy. So irradiation and antithyroid administration are directed towards destroying the overactive tissue or inhibiting the production of T3 and T4. So routes of administration. Iodide preparations such as potassium or sodium iodide, specifically Lugol's solution, contain iodide, and the way it works is that in large concentrations, iodide inhibits its own uptake and binding with the thyroid gland. Sorry, I'm kind of losing my voice here. These medications are not good for long-term therapy because the suppression is not permanent. Usually they're used preoperatively to get the thyroid to calm down so that it can either be irradiated or removed. So, side effects of iodide therapy: rash, headache, sore gums, hypersalivation, and itching. Radiation therapy or radioactive iodide. Emission of beta radiation from the radioactive iodide destroys overactive tissue. So basically it's used again preoperatively or in the treatment of thyroid carcinoma, and it can leave somebody permanently hypothyroid, which is where they would need replacement therapy. The most frequently used antithyroid drugs, these are oral medications, are propylthiouracil and methimazole, and these agents are thioamide drugs that inhibit the incorporation of iodide into tyrosine, which is basically creating the thyroid hormones. So these drugs usually put a patient into remission. They can be used long term. However, they can also be dangerous because they cross the placenta and can affect the fetus. Generally, if a mother has to use thioamide drugs during pregnancy, we recommend propylthiouracil, which is also referred to as PTU, because the transfer across the placenta is much less than methimazole. They also they also make it into breast milk, so you just want to make sure that nursing mothers aren't taking these medications, or maybe they're using formula instead of breast milk. Adverse side effects of thioamide drugs include rash, fever, myalgia, jaundice, and nausea, as well as agranulocytosis. It can also cause goiter therapy because negative feedback to TSH is removed. We'll continue on in another video for the parathyroid hormones. Stay tuned for part 2.